Okay, so objective and subjective method of neurological patient examination. I seen that you had some problem with the concept. So first of all, what do I mean here about objective and subjective methods of neurological patient examination? Because here we are talking specifically about examination, not about talking to the patient, in this moment at least. So we have different methods, yes. I suppose you have seen something like that now. So the Glasgow Coma scale. What is the Glasgow Coma scale? The Glasgow Coma scale is that, for example, you look at the eyes, you assess the verbal and motor answer of your patient, and after, and you analyze it step by step. So you analyze whether the patient. Generally, we assess those things after. Usually, after we apply some pain to the patient. Yes, so for example, we rub the sternum. Uh, for example, yeah, rubbing the sternum is the most common thing to do. So when the patient does not open the eyes, there is 1 point. When opens the eyes in response to painful stimuli, 2. When opens an eyes to response to voice, it's 3. Opens an eyes spontaneously, it's 4. Of course, when the patient opens the eyes spontaneously or to the voice, we do not need to rub its sternum. Yes. However, quite frequently, this scale is rather used to the patient that are unconscious. Verbal makes no sounds, incomprehensible sounds, utters incoherent words, confused, disoriented, oriented, converses normally. In case when the patient is oriented and converses normally, it would be very rare to assess such patient with the Glasgow Coma scale at all, to be honest. Motor makes no movements, extension to painful stimuli, abnormal flexion, withdrawal to painful stimuli, localizes painful stimuli, and obeys commands. So, generally, this is a way how to objectivize your what you see. Yes, because it's quite easy to say that a patient that does not open the eyes, that makes no sounds, that generally is not reacting to anything, is far worse condition than when opens eyes spontaneously, is oriented and converses normally, and so on. However, the Glasgow Coma scale is a way of objectivization of what you can examine on the patient. Yes. So this is the objectivization that I was talking about. How so? And how you can use this knowledge? Generally, imagine the situation. Yes, you get to some patient that is in severe state. Yes, and you ask a person that previously seen this patient, what about the patient? Yes, and he says to you, oh, okay, yes, or he says not so bad, or he says that's not very good, and then he gets back home, and it's your time to look after the patient. And in the end of the day, your friend comes back, and then imagine the situation. Try now to assess, to answer the question of the physician, who would ask you and your friend, what was about the patient? Whether the patient is progressing or not? Whether it's better with patient, worse with the patient? How to say it? Yes, it's very hard. It's very hard to compare your experiences between two persons. Yes, what you would say? Yes, imagine the situation. Yes, you had the patient. You are talking with the friend that already had this patient day earlier, and you want to get somehow the information whether he progresses or gets worse, whether the disease progresses or the patient is in better shape. Sometimes it's easy, yes, of course. If the patient was lying flat and then starts to talk next day, it's obviously better. But sometimes it's very hard. Such methods of objectivization, like the Glasgow Coma scale, but there are a lot of others, we'll talk about them in a moment, are helping us to compare. Yes, so when we know that one day the patient is Glasgow Coma scale 3, because as you can spot on this picture, the lowest possible level is 3. Yes, when you have 1 in eye, in verbal, and in motor, and the next day is 4, and the next day is 5, and the next day is 6. Yes, you see that the condition of the patient is better and better. Yes, so now let's get back to the story with you and your friend. You ask you ask the friend how was the patient, and he says 3 in the Glasgow scale. Okay, and now you assess him one more time in the end of the day, and on the Glasgow scale it's 5. The physician asks you whether he gets better or worse. You say he improved in the Glasgow Coma scale. So now it's very easy, yes? Because we have this objectivization, because we have a way to make from all of this information distill what is most important. Okay. But this is not the only scale. Through your career, you know a lot of different scales that are very important tools. Yes? Because one more time, looking at this scale, if you are reading it, all of it is quite obvious. Yes? Maybe apart from motor answer, but about this, why it is so, we'll talk a bit more later. But generally, it's all quite obvious that when the patient makes no sound, it's far worse than when he talks normally, and so on. But if I would ask you, without this table, to tell me exactly how to assess the patient from your head without Glasgow Coma scale, it would be extremely hard. Yes, you need such tools. You need such tools in order to assess the patient better. Yep. In order to be able to write it down, to make very short notes, in order to make it faster also and more reliable. So this objectivization that I am talking about all the time is extremely useful for you and for all other personnel that is working with you on some patient. Of course, Glasgow Coma scale that I was talking mainly about is for rather severe cases, but there are other scales that are helping you assess how your work is progressing, yes, whether the patient condition is improving or not, which is especially important if you are not working alone with the patient, yes, because if you are working alone, one by one with the patient, all the time the same patient, it's usually quite easy to assess whether he or she is improving or not. Not in all cases, but it's usually quite easy. But quite frequently you are not working alone. Yep. And the patient needs some documentation for many reasons. So that's why learn those scales, use them as frequently as you can. Even the good strategy is generally to try to use them in the clinical situations and learn through the practice, yes? Of course, you need first to remember that such scales exists, but then you can learn them through the practice. Okay, so this is another example. We have the Berg balance scale. So you have the patient is sitting or standing, standing unsupported, unsupported, standing to sitting, transferred, standing with eyes closed, standing with feet together. So these are the things that we assess generally. Yeah. Okay. We also have some tests to assess the mental examination, mental status, higher cortical function test. It's a complicated name, but generally it tells us how well the patient can think. So, for example, the patient with Alzheimer's disease would have far lower scores than you, for example. Yes. So if the person is normal, would score high points, a lot of points. If the patient is not thinking straight, yes, his thoughts are cloudy, let's say, cannot think fast, and so on, like Alzheimer's disease, like a lot of old person, but not only, like after alcohol abuse and so on. These mental examinations will tell us what is happening. Yes, and one more time, this is the objectivization of the situation. Yes, so this is a scale, and like all scales, there are tools, extremely useful tools. Yes, that will tell us what is the state of the patient, and also in this case, they sometimes are critical to say whether the patient needs treatment or not. Yes, so such kinds of states and then writing them down is extremely important. Okay, but some things are really hard to assess in objectivized way. And sometimes we need just to observe and examine and to write down just the definitions. Yes, so I will get this on example. Yes, we have here a lot of things. For example, we have inability to draw a clock or cross. So you ask the patient to draw a clock or cross, and well, if the patient cannot, you write down construction apraxia. Simple like that. Inability to comb hair or drink through a straw. Inertial abstraction. Inability to name fingers. Finger agnosia. Inability to recognize the object by touch. Asterognosis. Inability to recognize drawing number in hands. Agraphesthesia. This is quite nice test. Yes, so you make patient to close his or her eyes, and you draw, for example, 4 on the back of the palm. Yes, and as you ask the patient what is the number that you draw with your finger. Yes, and whether the person can answer this or not. Inability to understand written language, alexia, inability to write, agraphia. Okay, we can also test the pain and temperature for the needle, for example, and something hot, something cold, vibration, and the 2 points. Okay, stereognosis, graphesthesia, 2-point discrimination, double simulation, things like that. So generally, there are a lot of things that we can check. Yes, the light touch. So generally, in case of the senses on the skin, yes, so temperature, vibration, touch, things like that. We ask the patient to close his eyes, we touch, and we check whether the patient feels or not. We ask the patient. Yes. Joint position sense. So we also check the properties of our Golgi organs and generally proprioception. How to check the proprioception? The easiest way is to ask the patient to close his eyes and get the finger up or down, and ask the patient whether I gave your finger up or down. Yes, whether I moved your finger down or up. Do the same with toes, do the same with fingers, and check whether the patient knows where are the body parts of his. Yes. The another situation, how to check it, ask the patient to close his or her eyes and tell him to touch the tip of the nose or to touch with heel his knee. If the patient does not have a well-regulated proprioception, a well-developed proprioception, or he lost somehow his proprioception, he would not be able to do this, to perform those tests, because one more time, proprioception is how we know where are our body parts on the basis of the joints position. So proprioception tells us exactly where are each body parts, because it tells us exactly what are the positions of each joints. And by knowing the positions of each joints, our brain can count exactly where are our limbs, for example. And it does not work always. We have Romberg test. Romberg test, I suppose you also seen it, so you have closed eyes. The patient has, closed eyes, feet together. And when such patient closes eyes, you need to stand close to such patient, and we test whether he would fall down into our arms or not. If would stand, his balance is okay. If not, there is something not correct. Why we are asking to close the eyes? Because the patient can compensate his loss of balance with the eyes. Yes. So looking at the objects around, he would orient his body accordingly. But he should be able, all of us should be able to stand without the help from the eyes. Muscle weakness and wasting. So generally this is about lower and upper motor neuron syndromes that we'll talk more about on the separate case. About muscle tone we already spoken about. Okay, about reflexes, couple words. So generally, when we test the reflexes, it can be really hard to test reflexes well. Generally speaking, we usually test the we have couple groups of the reflexes that we test. Yes, for example, with this hammer that we talked about earlier. So when we test the stretch reflex, and we need to relax the joint before tapping, feel the tendon, swing hammer head to tap. Generally, you need to see it to know how to do it. But there is also the other group of the reflexes that you can test. For example, the Babinski sign that we also talked something about earlier. So we have some group of pathological neurologic signs that when present says us that there is some damage. Yes, that there is something bad. For example, Babinski sign, when we examine the sole of the foot, yes, when we touch the sole of the foot with something sharp, for example, one finger, the toe would go up and the rest of the fingers, of the toes, would go down. Yes, normally all of the toes goes down. In case of the Babinski sign, the toe, the big toe goes up, and this is pathological. This may say, for example, that there is a lesion in a spinal cord. But there are also some other signs, some other reflexes, but I suppose for you it would be enough for today.